now. I'm a nurse by background and have done a variety of both nursing and management and clinical governance roles through the health and social care sector.
Thank you. And as I said, my name's Emma, so I am Head of Quality Assurance. I've been with the Good Care Group for 6 years. I actually joined the Good Care Group on a graduate scheme for the Department of Health. Worked as a care manager in central London for a couple of years before moving over to quality assurance. So this evening we have got 2, potentially 3, I think, joining us, client representatives, so family members of our current clients. So I think it'd be good if they could introduce themselves. Shenka, are you okay just to introduce yourself?
Oh, hello everyone, my name's Shenka Christmas. I have been a client of the Good Care Group for 6 years now, and the Good Care Group looked after my mother and when she had Alzheimer's, and they are still looking after my father, who is bedridden.
Thanks, Shenka. And Moira, are you happy to introduce yourself?
Yeah, I'm Moira Rose. I've been a client not for nearly as long as Shenka, just for about sort of 18, just over 18 months. My father's sort of got 2 carers now, living carers, and he's increasingly frail, but he's got all his marbles at 97 next week.
Thank you. I'm not sure, Alison, are you
on the
call? You are.
Yeah.
Are you happy to just introduce yourself, Alison? Tell everybody a little bit about yourself.
Sure. So I'm Alison. My dad is cared for by the Good Care Group starting in March this year, so just over 6 months when my mum sadly passed away. So my dad is 99. He has a little tiny bit of dementia, but he knows who everybody is, and we have 2 really amazing carers who work on 3-week on 3-week off shifts. And I had a private carer before I had the Good Care Group come and care for him. And the difference in my father has been incredible.
Thank you.
Yeah.
Thanks. So what we'll do, we'll run through a short presentation where we'll just give a bit of an overview of sort of different care options that are out there, including live-in care, and then we'll tell you a bit about the Good Care Group and what we do. We've got the questions that anybody's already sent in, so we'll try and answer them through the course of the presentation. If you've got additional questions, if you can just use the chat function, so it's just the little sort of picture of the message, if you like, so you can type into there and we can see your questions, or if you hold them until the end, we'll allow you time to sort of verbally ask. And please do make use of Shenka and Moira and Alison, because they have experienced sort of live-in care as clients firsthand. So if you've got any questions specifically for them, please do ask.
Okay. So we'll go into just around, just go through some slides that we've sort of put together here. But as Emma has said, you know, if we don't cover off any of the questions that you want answered in the slides, then please do feel free to raise them, put a question in the chat box or raise them afterwards. We'd like this to be sort of a fairly interactive session. So as I say, you know, the aim of the session is really just to give you an idea around care and what it's all about. And we know that, you know, it is really quite difficult when you're starting to begin the process of looking for care, because it's quite a bit of a minefield out there, knowing where to go, what options to choose from, what the different types of care are. And sometimes it's when people start looking for care, they start looking when they are actually at crisis point. So I suppose, you know, our message to a lot of people is that it's never too early to start talking and looking and thinking about care and what the plan should be, and start having those conversations around what you as the family would like, what your relatives would like, or if you're actually the person that's getting the care for themselves, just start thinking about that early doors. Quite often care, as we've got there, is a bit poorly organised. It's done quite in a hurry, and as I said, it is actually done at crisis. And then trying to gather information when you're already in a little bit of an anxious state makes it quite difficult, and it's quite difficult to try and think of, you know, of making a decision. But there are a lot of different types of care out there. And as you can see from the slide, you know, there's what we call ongoing care. There is care that can be done in a care home. There is care that can be hourly, so you can have somebody coming in to sort of give you an hourly support. That could be at lunchtime, that could be in the morning, that could be in the evening, depending on your needs. Then there's another type of care where what's called respite, which is for a short period of time. If, for example, perhaps a loved one needs to go away or wants to go away on a holiday, so they need just sort of care for a very short, defined period of time. There's care that can be done in your own home, and there's what we would call live-in care, which is where you would have a carer coming into the placement and living with you, so that it is a 24/7 care that's provided. And just looking at how does living care work. Living care is a carer staying in the family home. So what we would suggest from the Good Care Group's point of view is that the carer would need to have a bedroom, so that they can obviously have somewhere for them to go and sleep, and that they would need to have access to things like Wi-Fi in order to be able to do some communication with their families, and quite often when you're having a living carer, then there is a requirement to have that carer to have some break time, so that they can actually go out and do their own shopping, have some time away, because it is 24/7, as I say. The care can be provided by one person, or it can be provided by a team on a rotational basis. And I think you heard from Alison just there talking about the fact that she has 2 carers doing 3 weeks on and 3 weeks off. So there's a whole option of what sort of rota patterns can be provided in order to be able to deliver that care. And it is provided, as I say, on site, 22 hours a day with a 2-hour break, in order to make sure that those carers can go off and get some of their shopping done. For us at the Good Care Group, we have our care done in what we call daily average hours. So our carers do not work hourly, they're not paid hourly. What we look at is the needs of the client, and we work out over the 24-hour period how much time we think that carer would be engaged in active delivering of care, and that's how we would then work out whether it is a 10-hour or a 12-hour day that's being provided. We would ask our clients to provide full board for our carers. So as I say, that is a bedroom, and that's 3 meals a day. And then the carer delivers a care against an agreed care plan that's been set up and agreed with both the family and the client themselves, if they're able to make those decisions, looking at the needs and very much tailoring it around both the social needs as well as the care needs, and how that needs to be delivered. We would look at environment, we'll look at moving and handling, we'll look at any specific needs of the person, and we would look at, as I say, if there's any family requirements. Sometimes people like to go out and about, hairdresser, they like to have people in, social events. It is very much a whole holistic approach to living care, and that's how we would do the care.
And somebody asked a question in advance of this around how we work with GPs, given that doctors aren't sort of based on site like they might be in a care home.
Okay, so we work very closely with the GP. So initially, as part of our assessment process and then part of the ongoing management, we will get a GP report, which we will obviously get consent to get from the GP, and that will give us an overview of medications, medical history, and we will let the GP know that we are now taking on the care of the client and what that looks like. And our carers are trained that they will work very closely with the GP. So whilst, like you have in a care home where you have a regular round where the GP comes out, we will work very closely with the GP as you would do in normal sort of circumstances living in your own home. So as I say, the carer will contact the GP and do any liaising with the GP that's required. Again, this is done in conjunction with the families because each individual person works differently. So sometimes our carers do the engaging with the GP. Sometimes clients or families want to continue to do the engaging with the GP. So we would get the carer to be communicating to the family if they thought that there was any need for the GP to be contacted. So the client was unwell, that they felt that somebody was a little bit off their food, or they looked like they'd got a temperature, or anything that would cause concern. So we do that on a sort of a daily basis. We've got some of our carers and the GPs have got a really good sort of working relationship around some of our clients that potentially might have repeat infections. So they work out very much a strategy of managing and dealing with that. And our carers and our care managers, because each of our clients has a care manager that manages the placement, would also be involved in doing communication with GPs. We work very closely with all healthcare professionals. So we would work with district nurses, we would work with physios, occupational therapists, speech and language therapists, and if there was any other professions that we needed to be doing liaising with, the carers or the care manager would take that on as part of their role.
And Moira, I don't know, is there anything that you think maybe you'd wish you'd have known about how live-in care works when you first joined the Good Care Group?
Not particularly, but we'd had sort of private carers just by the, sort of not by the hour or by the 2 or 3 hours. And it was when one of them who'd become really more like a friend to Dad said that she was going home and taking her phone home and taking it to bed with her, that we thought that perhaps we needed to go further. And at that point, I think Dad did not want to go into a home. He was quite adamant. And he said he had the money, he'd been saving it up, and he could afford it. So I suppose what we did then was we looked into the options.
Yeah, thank you. Okay, happy to carry on, Jan?
Yeah, to carry on. So we've also the next slide will talk about the benefits of live-in care. So I think, the first slide just talked very much about all the different types of care options. And again, that has to be considered. And there are a variety of options out there. And as Moira's just said, she started off with an hourly provider, a carer that was doing hourly care. And I think there does come to a point where that hourly care needs to be increased, or the needs grow. And obviously hourly care can be increased 1 hour, 2 hour, but I think when it comes to sort of then thinking about, well, actually we're talking about more of the day where the client needs that sort of support, needs the comfort to know that there's somebody around to help the person at home. Then we start looking at the benefits of having somebody living in with you, and from my perspective, I think from the whole of the Good Care Group, all of the people that work for the Good Care Group, we're very, very passionate about the fact that being in your own home is actually the absolute best option for the majority of people. We do recognise that there are some situations where you may need the care home may be an option, but for the majority of our clients, the benefits of being in your own home where you have your memories, you have your belongings. If you've got pets, the pets, will remain there. Your daily routine doesn't need to drastically change. It just needs to be perhaps tweaked, if I say that, in order to be able to cater for your changing needs. But you can keep those relationships up. You can keep those community ties. I talked just earlier about still going out to the hairdresser, still having people coming in into your own home, still being able to have the home as the hub and the place where the family still meets. Also, having a living carer is, as it says, there's one-to-one care. When you go into a care home, you will tend to have a number of clients that one carer is looking after. The benefits of having living care is that you do have your own carer, and therefore you can change your day according to however you want to change it. So each day doesn't need to be the same. What time you have breakfast this morning doesn't need to be what time you have breakfast tomorrow morning. There is the flexibility around that. There is the opportunity to retain independence and as I say, live the way you want to live. I think it's much easier when you're in your own home to maintain that independence. Even if it's reduced, it's still a lot easier than if you are somewhere else where you're reliant on somebody coming along and doing something in a specific way at a certain time. The care plan is very personalised, so it is around your needs, what or the client's needs, what the loved one's needs are, and that is different for every single person. It does avoid a move, as I said. That there is no need to sort of to sell your house, to try and move your whole life's furniture into one room. You do stay in control. For us as well, I think couples is really, really important because couples can stay together. I think sometimes when maybe couples have different levels of needs, so one of the couple has dementia and the other member of the couple has perhaps reduced mobility, to try and find a care home where you could keep everybody together with the different level of expertise is sometimes a bit more difficult, whereas in your own home we can provide a carer that can deal with both of those. So you can stay in that loving partnership as has been for a number of years, really. You can attend clubs and you can just live your life as you'd wish to live it. So I think that's the most important thing for us.
And Shenka, someone asked a question in advance about couples and whether having a carer sort of enter the place sort of alters the dynamic or how that works. Would you share your experience of how that worked with your parents?
Certainly. So when the Good Care Group came in, my mother had Alzheimer's. My father had all his marbles, but was not at all well physically. The dynamic before the carer arrived was pretty toxic because my father didn't understand dementia at all and just harangued my mother and made her very anxious and even made her even more confused. And then he got hurt and it was absolutely horrible. When the carer came in, the carer was able to diffuse all of this. The carer understood how to deal with dementia. My mother was much calmer. The carer occupied her in ways that she found fulfilling and really did wonders for her, which meant that my father was much calmer and more reasonable. The carer didn't invade the privacy of my parents at all. They still had time with each other so far as was sensible. So I hope that gives you some of the flavour, but if you've got more questions, then do ask me.
Thank you, that's helpful. And then Alison, one of the other questions somebody asked was how they would know, or how families know when it's time for live-in care. Would you mind sharing your thoughts on that?
Well, mine was a bit last minute, but my mum passed away quite suddenly. She was 94 and Dad was 99. He's 99. So Mum was really sharp mentally, but physically had a stroke, and therefore wasn't very good. So they'd worked. I realised that in hindsight they'd worked as this kind of team. And as soon as Mum died, Dad was an absolute kind of lost soul. So we went through the process of a friend recommended somebody, and we took a lady on to try and do some private care. And that didn't work out. Prior to that, they had carers going in part-time. But I realised that my dad was absolutely terrified of being on his own. And that was my reason for eventually coming to the Good Care Group to find someone to be there all the time. And it's taken a good 6 months for him to actually understand and believe that there is someone there all the time. He still gets slightly anxious about it now if the carers aren't kind of visible. So my decision was kind of forced upon me.
Thank you, that's helpful.
Again, happy to answer anything else.
Thank you. So just to give you more of a sense of, obviously the Good Care Group is a live-in care provider, and we've heard a bit about live-in care. So I'll just talk through specifically what we are able to offer at the Good Care Group. Obviously, every care provider is different. They are able to provide slightly different care. It varies in cost, in quality, in sort of arrangements. But we are able to provide couples care. And as Jan said, you know, that's a favourable option for many people who want to stay together in their own homes. And actually, in many ways, it can be cost effective, because for many people, they're able to have one live-in carer supporting both parents, as Shenka did. Whereas if you were to move both partners into a care home, you would be paying for the cost per person. And as Jan sort of briefly mentioned, it allows for varied needs. So you may have one person who's physically requiring more care, or one person who maybe has a cognitive impairment like dementia, and a live-in carer is able to sort of manage that dynamic and meet the individual needs of both parties whilst keeping them together. We also provide dementia care. So our carers go through a sort of specialist training program, which is based on a kind of blended approach of techniques. So very much rooted in person-centered care. We also use an approach called the Speckle method, which kind of helps our carers to understand the person with dementia, and asks them to sort of see things from their point of view. So our carers are encouraged not to contradict clients with dementia, not to sort of argue with their reality, avoid asking them too many questions, which can cause sort of confusion or distress. And having a live-in carer, you know, you see the same face every morning. That person knows you as a person. They don't have to ask how you take your tea, what you'd like to eat. You know, they become a friend, and they become a familiar face, which I think is really important for people with dementia. And actually, one-to-one care, you know, we've measured our outcomes over time, and we know that having that familiarity and that sort of wraparound care reduces anxiety and in many cases sort of behavioural challenges. So we find that people are supported to take fewer antipsychotic medications, which many clients take when they're in care homes because their behaviour needs to be sort of controlled, for want of a better word. Our clients are able to, you know, do whatever they want within reason in their own homes. We also are able to support people right to the very end of their life, if that's their wish and if they'd like to remain at home, which is important for many people. And I know a couple of people asked questions about end-of-life care and how that works. So I think it's worth saying that we absolutely can provide care to the end of somebody's life. It may mean that that requires an increase in care. So the person might need 2 carers, for example, if they needed support turning in bed, or if they needed somebody overnight as well as during the day. I know Moira has 2 carers now because her father needs support. Is that with moving and handling, Moira?
Yes, I mean, he doesn't actually need extra people overnight because he sleeps like a log. But he does need for moving and handling. He's lost all strength and muscle tone and all the rest of it.
Yeah. So as long as we can have, you know, as many carers in the placement as are required, if we needed 2 carers, we could absolutely continue to support. What our carers do, thanks Shenka. So Shenka's father also has 2 carers. And what our carers will do is work with community teams. It might be hospice at home teams, it might be district nursing teams. And we are very aware of sort of the provision available in local areas across the country. So our carers will monitor signs and symptoms, whether that's sort of pain or distress, and then they can make referrals, make telephone calls. You know, usually 24 hours a day, the support is available, and then the people will come into the person's own home and deliver care at home. So I think somebody asked a specific question around how we deal with sort of pain and distress at the end of life. So very much as anybody would in a hospital or a care home, it's just that the carer is the person who makes the sort of on the spot referrals, if you like, and often will have medication in the placement that can be administered if we see a certain set of symptoms. So sort of last year, nearly 80% of our clients who passed away did so at home. So we're really proud to be able to support that, because, you know, it's something that most people want. They don't want to have to leave their homes. They don't want to go to hospital at the end of their life.
And I think just if I add to that, so from the Good Care Group's point of view, we do have what we would call a nurse-led product, for a better word. And again, we've got an ADMIL nurse, a qualified nurse, who would oversee that care plan. And again, for them, it's very much around working with the care manager, making sure that we are keeping an eye on all of the medications, on the pain relief management, behavioural management, because sometimes when people are at end of life, they become quite, you know, they can become quite distressed, especially, you know, if they're unable to communicate clearly around, you know, around pain and the anxiety. So we work very closely with our own team as well, monitoring and reviewing the care that's being delivered on a sort of a regular basis. And as I say, our ADMIL nurse works very closely. We've got an IT system which allows us to be able to see our medications, and our care managers and our carers can communicate very, very closely around medication management and reviewing that, and again working very closely with the GPs. So that's quite an important part of our framework and our structure for making sure that just because you're at home, you are still going to get you know, the full level of support required to make sure that you know, we support everybody right to the end of life in a what we would call a good death, and that's really important, I think, for everybody.
Yeah, absolutely. And then lastly, we're able to sort of support with recovery and reablement. So we have, as Jan said, we've got a nurse-led service for clients with sort of higher needs. We also have an OT, an occupational therapist, working specifically with us. We are the only live-in care provider with a full-time OT. And what that enables us to do is support hospital discharges. So we look after people after they've had either sort of planned surgery, or it might be emergency surgery after perhaps a hip fracture or a serious fall. And Jackie ROT is able to support, ensure that people have the correct equipment in their homes. It might be a hospital bed or a hoist, as well as sort of look at reablements where we know people fare better in their own homes if they are sort of rehabbing back to full independence.
Okay. There were a couple of questions asked, Emma, earlier on.
So there's a question about matching, which I think we'll probably go on to when we talk a bit more about, we've got a slide specifically on the Good Care Group, so we'll probably cover that then, if that's all right.
Yeah, no, that's fine. And there was one just around managing it, around carers managing, taking over the role that's being fulfilled by the spouse.
I think we answered that one.
Okay. I mean, that was one of the questions, was just around if the spouse has predominantly done the care, and then some other carer comes in, and how does that role change, and how does the spouse be able to step away so that the carer can then deliver that care? And I think, as Emma said, it's very much around making sure that we work together, we develop strategies, and we make sure that we go at everybody's pace to support everybody in the family. Okay, so the next chart is just to look at but the residential solutions, and but the benefits and how to choose. And so from a staffing point of view, so there's around flexible staffing model, moving and handling required 2 people, and care needed day and night. And that it's it is a purpose-built environment, and that from being in a residential setting, there are all the household issues are taken away, and we do recognise that not everybody wants to remain in their own home. So whilst from the Good Care Group's perspective, as I said to you earlier, we think that the majority of people would choose to stay at home. We do recognise that actually there are some reasons why people would choose to go into a residential setting, and there are some things that some families might find a little bit stressful, and some of it is very much around continuing to need to manage the household, and continuing to need to sort of keep an eye on what's going on, and sometimes families will make a decision that that's why they need to go into a residential setting.
So sorry, Shenka's made a good point. So when we talk about residential solutions, we're talking about care homes. So I think it's just recognising that there's absolutely different options out there. So one of them is moving into a care home, which might be a nursing home, providing a sort of higher level of nursing tasks, or it might be a care or residential home where it's typically sort of more companionship. So we just wanted to sort of highlight that, for us, we're very proud to be able to support people in their own homes, but it's absolutely not the only option out there. And we can understand that for these reasons, people might consider moves to a care home. And I think if you are looking at a care home option for a loved one, there's a few things that you'd probably want to think about in order to decide. So I think, visiting, talking to residents, observing whether staff are engaging with residents, and actually understanding staffing levels. So obviously one-to-one care at home, you're not going to be able to beat that staff ratio, but understanding how many people are on shift at any one time in a care home is really important. The quality of food, that would be number one on my list. and understanding what sort of activities are available. Are people supported to go out? Can they engage in group activities, single activities, if that's what they're interested in? And then having a sort of look round, is the place clean? Is it well maintained, well kept? And, you know, our sort of top tip would be to turn up to a care home, if you were looking at that as an option, unannounced and asked to be shown around, because you just get a better sense of what things are like.
Yes, and I think that, you know, I think the more research you can do, and the more the more time, I suppose, you have to make those decisions, the better it is. I mean, as Alison said, you know, her decision had to be made very quickly, and we recognise that you know, some decisions need to be made very quickly, and that's why I think it's good to have, you know, start having conversations early and have a what's an essential, what's a desirable. I know that might sound a little bit sort of odd, but I think, you know, very much around, because what might suit one person will not necessarily suit somebody else. So again, it's very much what fulfills your requirements for your own individual needs. So the next one is just to talk about this when you're starting to look for care, whether it be in a care home, whether it be care at home, whether it be hourly care, whether it be live-in care. There are two different types, and there's one called regulated and there's one called unregulated care. And when you're starting to look out there at the vast number of providers of care, I totally recognise that it can get quite confusing. And then when you start to look at costs and what does it all mean, it just again, it can feel like it's quite a sort of daunting task. But from a regulated versus unregulated point of view, that is around whether the provider is regulated with the Care Quality Commission. So in order to be able to be regulated, we have to register with someone called the Care Quality Commission. Lots of people probably have heard them because they do inspections in hospitals as well, and that's where we will get our rating. And because we are any regulated organisation is inspected by the Care Quality Commission, there's a set of standards that we have to meet in order to be able to get a rating. So the ratings go from outstanding to requires improvement. So and the Care Quality Commission will give that. There are some providers that are unregulated, which means that they obviously haven't registered with the Care Quality Commission, and they probably will not necessarily contract the staff. They will almost be like an introductory sort of agency where they will find a carer, and that they will then offer that carer out to you, but then you will be responsible for then sort of employing that carer and managing that carer. And again, you know, I think it's what you need to do is just sort of understand all of the benefits of both of those. So from our point of view as a regulated, we employ all of our staff. We do all of the checks on them. We do all the police checks, the recruitment checks. We do all of the training for them. We do all of the management of them. We make so our care managers manage them, appraisals and supervisions, performance management. If that carer doesn't suit the client's needs, or we need to change that carer, then as a regulated managed service, we would make sure that carer is removed and bring another carer in, whereas in an unregulated environment, you don't get all of that sort of management support.
Alison, I know you had private carers for a while, and you mentioned that didn't work. What was if you don't mind me asking, what was the reason that didn't work for you as a family?
Well, it was very last minute, but I had someone recommended to me who was known and who, you know, I did as much checking, I got some references, etc. But the bottom line was, when she got there, she didn't, sounds really awful, she didn't really want to care. She wanted to kind of sit in the house and do nothing. So my dad, I felt like very quickly her irritation, and my dad, he does repeat himself, but she didn't have the training or the ability or the desire to want to do that. So I think it is it's a minefield trying to find somebody yourself, because you can ask so many questions, but you don't know until they get into your home. And once you've got them in your home, you've then kind of got to find someone else or find a different solution, and you've got to try and do all the management of that person to explain why they're not caring for your dad well enough. And I know that probably makes me sound like a daughter that's kind of over anxious, and I was definitely. But my dad ended up in hospital, and she was only there for 2 weeks. So I would say beware anybody of going that route unless you're very sure about who you're having in your home.
And I think that's the key difference. So unregulated care requires you as a family or a client to manage the care, if you like. So obtain references, do any sort of background checks, and also provide sort of backup support. So somebody asked what would happen if our carer was sick or needed replacing. So we have a backup team of carers who are available, and we have a number of carers on standby at any one time. So in an emergency, you know, things happen, carers fall sick, or their trains are delayed, or, you know, whatever it might be. So we have people that can be there, and in the 11 years that we've been running, we've never left anybody without care. But also, I suppose, in situations that are less of an emergency. So, you know, there are times when carer and the carer and the client just don't gel for whatever reason. It's a lot to have somebody move into your home and expect you to get on well. And I know, Moira, you've had a couple of experiences where carers haven't quite worked out and they've had to be sort of replaced.
Yeah, yes. I was talking to my sister, and we actually reckoned there were 3. None of them were an emergency. We didn't turn around and say, "Help! This is just awful. Please do something about it now." We were able to wait in all 3 cases until they'd finished their rotation, their stint with Dad. Their first, some were 3 weeks, some were 2. One might even have been 4 weeks. But we did say to the Good Care Group in time, said, "Please, this is not working." One of the things was, I don't know how it happened, but Dad had asked for non-smokers, and one of them, the smoking was so obvious, the house stank of smoke. And that was, you know, Dad said he was struggling with that. And then there were other things I will not go into, but they were all replaced very quickly. And at the moment, we're very happy with the 4 that we've got. Yeah.
Thank you.
Okay. So what to look for all care settings. And I think this is, you know, as I say, no matter what sort of providers you're looking at, you know, it's really, really important that you look at the recruitment process and the background checks. So even if you're probably going to look at an unregulated environment, then you know, it's still worth asking about, you know, well, what sort of checks have been done, or if you're going to look at privately employing your own carers, again, you know, make sure you can do as many sort of checks as you can. We obviously do all the police checks, we do references, we do occupational health checks, and we have a whole sort of recruitment process. So really make sure you try and do your background check. What to look for in all care settings, just around staff turnover, you know, try and ask those questions around what, you know, well, what is your staff turnover? I think, you know, that's a key, especially I think when you, potentially when you're, you know, if you're going to look at maybe in some of the more, what I talked about earlier was residential or care home residential settings, you know, what's their staff turnover like? Because sometimes you do find some environments where you get a high turnover of staff, and that's indicative of sort of maybe values and culture going on. Ask about what training you do, you know, what does the organisation provide for the carers and for the rest of the staff around training. We've just talked about it very much around staff contingency and agency use. So if your carer went off sick, you know, what would be the contingency? What are the plans? Definitely when you're looking at sort of your residential type environments, ask about the agency use. You know, do you use agencies? I'm pleased to say at the Good Care Group, as Emma has said, we have never left a placement uncovered, and we have never covered a placement with a member of staff that has not belonged to the Good Care Group. So, you know, that's something that we work very hard at. And we make sure that we have a contingency plan in place. So again, if you're going to look at a nursing home, you're going to look at a residential home, find out how many agency staff they use. See if you can find out about, you know, any sort of, you know, how do they check for how do they assure the quality that's going on in their, either in the service that they're delivering. You know, do they do spot checks? Do they do audits? You know, how do they manage to make sure that they know that the service they're delivering is a high quality service. Have a look around about the expertise, you know, what sort of, you know, what's the team made up of. So from the Good Care Group's perspective, we've got an Admiral nurse, we've got an occupational therapist, all of our management team, our care managers, our regional managers, our head of operations, our quality assurance, head of quality assurance, Emma, myself, we have all been in the care environment for a number of years. I was talking the other day and saying that I've actually been a nurse for 40 years now, so I'm sort of feeling quite old when I talk to some of my younger team members, but all of our staff have got a high level of expertise within this sort of field. And again, you know, talk about, can people stay to end of life if they wish to, you know, can the environment manage to meet those persons' needs? Sometimes when you're looking at a residential type environment, sometimes the difference between a residential and a nursing is that obviously a residential setting doesn't have qualified nurses there. So it may well be that they may then need to move that client to a nursing environment because they can't meet that person's needs. So it's just checking all of those out and asking those sorts of questions. We talked very much about, is it fully managed? Again, you know, that's, if you're looking at care in the home, that's a really key question to ask, because there are a lot of providers out there who don't overtly say whether they are managed, fully managed, and so I think that's a key question to ask. If you want to know that you know, that's a definite words to use. Have a look and see what other people say. See if you can look around for testimonials, look at Trustpilot, that sort of thing. See what people are saying. Again, I think, you know, looking about whether they will make improvements to your quality of care. How do they look after their carers? You know, what sort of benefits do they offer their carers? How do they support their carers? So from the Good Care Group's point of view, we've got a 24/7 support line for our carers. We've got care managers who support carers with appraisals, supervisions, that sort of thing, how the care is managed and supported. And the last most obvious thing from a regulated environment is very much around, what does CQC say about them? because the CQC have a core set of an inspection framework of which they will inspect every single regulated provider. So the rating given by CQC is an indicator, because it should be consistent across all regulated environments. And is it possible to get any references, obviously, from existing carers? You know, what care availability is like, all of those sorts of questions. To be honest, no question is a question you shouldn't ask. So if there's something that you want answered because it's really pertinent to your loved one or to you as a potentially, you know, clients themselves decide on the care. If there's something that's really, really important to you, then ask that question, because that will help you determine where you want to go.
And if we move on to the next slide, I'm just quite conscious of time, and we've got quite a few questions. So a few of the questions, I'm happy to answer them almost as one. So a few of the questions are around sort of the level of care experience our carers join with, and the matching process.
Mm-hmm.
So I suppose what's important to note, so all of our carers come to us with previous care experience. Because we are putting people into a live-in care environment, it's really important that they are trustworthy, are skilled, and are experienced enough to operate independently. So all of our carers have at least 6 months care experience, and they go through a rigorous recruitment process, which also involves a sort of 5-day in-house induction training program, which forms part of the recruitment process as well. So during that week, we're monitoring them through sort of learning assessments, but also observing their values and behaviours through the induction week that happens in our office in London. With the matching process, so we have a whole range of criteria based on people's skills and experience. So we place carers who have worked with people with dementia or with Parkinson's, with people with those conditions. People might have sort of certain criteria, like they'd like somebody who can drive because they might live in a particularly rural location, or their loved one might like to go out and about quite a lot. Other people have quite specific requirements around cooking, or just sort of a personality. So some people prefer a bubblier, more talkative carer, whereas other people prefer a sort of slightly more shy, or someone who blends into the background a bit more. Shenka, someone's asked specifically about sort of, as a family, how you found the experience of kind of matching with carers, and how the carers have just fitted in with your father.
Well, we've had a number of carers over the 6 years. Most of them we've got on really well with. Some of them have become family friends. There have been a couple that didn't work out. When I say a couple, I mean 2 that didn't work out. There was one young lady who really wasn't experienced in running a house, because part of the job is being a housekeeper, really, running the house as well as looking after the client. And this young lady really didn't have enough experience of that. And so she only lasted 2 weeks or something, and then was replaced. There was another carer who, while being very competent, somehow rubbed my father up the wrong way. I think she was too bossy, and he felt bullied by her. And she lasted, I don't know, a year or so, but then it got worse and worse, and by mutual consent, she left. But on the whole, the carers, they have fitted in very well with the family.
Thank you. And Alison, I know you said you came to us in a bit of a crisis. What was the sort of lead-in time between you speaking to us and everything being set up and established? Can you remember?
Yeah, about 3 days. So okay, literally, wow. I think I called, spoke to, I've forgotten her name, in the office. Daniel literally came out the next day, and then I think we had a weekend in between, and I think the lady started on the Monday. The first lady started on a Monday. And it wasn't a case of, right, you know, you've got to have this person. But we went through a few kind of CVs and things and chatted about them all. And amazingly found 2 fantastic people straight away. Obviously, that's not ideal.
No, well, sometimes it works out, and I think so. In terms of the kind of process of setting up care, we absolutely can put things in place quickly. You know, we have teams of carers who can potentially start placements very quickly, sort of, you know, within 48 hours if it's an absolute crisis. But it might be that those carers aren't the ones who then stay and become part of the permanent team.
And I think that was what we said in the first place, that these, you know, if this doesn't work out, these 2 were available. The first one was available.
Yeah.
And then we had a bit more time, obviously, to find the next one. But it was always going to be right, this is kind of the best person we think. And, you know, we'll see if it works. And luckily it did.
Yeah. And I think sometimes that's exactly what happens. And sometimes on paper, looking at their profiles and their experience, you can find a carer that you think is absolutely the perfect person. And as you say, for some reason that it just doesn't work. And I think from our perspective, and I think, you know, what we would advise everybody is that sometimes it doesn't work out, and you can't actually work out potentially why, because it looks like it should, and it doesn't. But that's okay, because the aim is to, you know, is to find the right person. And, you know, sometimes we're, you know, it's really lucky and it works really well the first time, and other times for various different reasons, it does take a while to find the right carer, because you're trying to find the carer with the right skills and experience and training, but you're also trying to find the right personality that matches in. And then there are other requirements, like, you know, so, you know, if we needed to find a driver, which, you know, finding carers who drive is, you know, there aren't many carers that drive. So you know, trying to match all of that is a bit like a jigsaw puzzle. So but we work through it together, and I think that's the most important thing, isn't it, really? Just working through it together, really.
And Jan, someone asked, is there a trial period put in place
For a carer or for the actual placement?
So I assume for the sort of provision of care. So if someone were to engage care.
So there is a 14-day cooling off period. So for any startup of a placement, yes, there is a 14-day cooling off period. So if after the, you know, the 14 days it really is not working, then the placement, you know, then can be ended. We do have the opportunity to do respite, which is very much, and sometimes we've had clients where they've been very unsure about whether this is the way they want to go, whether the mum and the dad will even accept it, because it is bringing somebody into a home, and that sometimes is quite difficult. So there is the opportunity to have respite, which is 14 days, to see how it goes. And if it turns out that that's actually going really well, then there's an opportunity to change it into what we would call an ongoing placement, and then sort of then go on from there. So there are sort of, you know, some options around, you know, if it's something you're not quite sure about.
And there's a couple of questions that people submitted around sort of behavioural needs. So whether we would be able to support somebody with quite challenging behaviour due to perhaps dementia or a cognitive impairment. And I think, you know, we don't want to promise that we could provide support for everybody, but we have got our consultant Admiral nurse, who is a specialist in providing support for people with dementia and their families. So that's a resource available to us that enables us to provide people with quite complex needs care in their own homes. Shenka, I know your mother had some sort of behavioural concerns that we were able to manage at home but hadn't been managed in a care home. Is that right?
That is right, yes. She was very aggressive before the Good Care Group came on the scene, and then became much calmer. But over the next 18 months, her Alzheimer's got worse, and there came a point when the care manager said, I don't think we can continue to care for Jill at home anymore. We suggest that you start looking for a specialist care home for dementia. And that's exactly what we did. We felt terrible putting her in a home, but it was the right thing. And so, you know, the Good Care Group was very realistic about it. They coped with her for as long as they could, but when they realised that it was no longer sensible to look after her at home, they told us that it was time to look for some other form of care.
Yeah. And I think thank you very much for that. And I think what's important is that, you know, it's supporting that decision making, isn't it? Really, it's and helping with that sort of transition, really, as well. So
exactly, we were given a lot of support by the Good Care Group in that, making that decision and making that transition.
Thank you. And is anyone, if we haven't covered your questions, feel free to sort of unmute yourself and ask away or put it in the chat. I'm conscious we've had quite a lot of questions that hopefully we've answered through the presentation, but if we haven't, please feel free to ask now. And if not, maybe with the client representatives, if we just unmute you each briefly, do you want to just share any top tips for people looking for care, or anything that you wish you'd have known when you were sort of at this point in your journey? Moira, I don't know if you're happy to sort of start.
Yeah, in a way, we didn't have too much agonizing to do, because we'd had this wonderful person who'd been there. And then when my mother had to go into home because she had dementia, the carer that had been in for Mum just stayed on looking after Dad, who at that stage was really quite fit and relatively able. And it was only when it became too much for her, but she didn't say, one day I'm off. You know, she left it to us to try. And what we did was, my sister, I won't go into what she does, but she knew about CQC and reports and all that sort of thing. And she spent quite some time trawling, mainly CQC reports of anything that might have been local, or been able to provide something locally. And we looked at those, we spoke to people, and it was the Good Care's wonderful attention to detail and being communicative, as well as the good report, that won the day.
Thank you, that's helpful. And I suppose that's a good point. So if anybody is looking for care options, just going on to the CQC, so that's the Care Quality Commission, the website, you can see every report for every provider, whether it's home care, care home, you know, you can look at it all on there, and it gives you a sense of the quality of the organisation. Alison, anything for you? Any top tips?
I was going to say the CQC thing as well as the start point, but I think you get a really good sense by the people that answer the phone straight away in the office. And, you know, some people wouldn't even call you back. I don't mean the Good Care Group, obviously, but, you know, and you just think, well, if you can't even be bothered to call me back, you're not going to look after my dad. And I think that kind of initial gut instinct is a really important one to hang on to.
Thank you. And Shankar?
Yes, I would echo what was just said. When I was at my wit's end, trying to plan care for my parents, I phoned the Good Care Group kind of almost by mistake, and I just got through to someone who sounded so reassuring and so in command of the situation and so skilled that I knew I was in the right hands, and I have never changed my mind about that. And just another couple of points. The carers are all well cared for themselves. They're looked after by the Good Care Group, and you can tell that they're well supported, they're well paid, they're motivated, and that means that they do their job really well. Another thing I'd like to say about the Good Care Group is that they're brilliant at strategic thinking. So they've planned how to deal with the COVID crisis brilliantly. When it looked as if my father was dying, they said, right, let's make a plan for when he dies. What do you want? You know, what would you ideally like to happen? Let's have a plan for your father's death. Actually, he's still alive, but it was wonderful that that plan was made and that plan is still there. Thank you.
Thank you, Shanker.
I'd like to second that on the whole COVID thing as well. I had so obviously I have carers 3 weeks on, 3 weeks off, but my carer ended up staying for 17 weeks because she felt that it was the right thing for my dad, and that means an awful lot to me that she did that.
We had one who stayed for 16 weeks.
Yeah. I mean, that's an amazing thing to do, isn't it?
Yeah. Thank you. We've got so much to say about our provision of care during COVID, but I'm not sure we have time to cover it all.
And I'd just like to pick up on that though. So I think that it is so important to make sure that we are prepared and we are ready and we are planning, and the aim of the Good Care Group and it being a managed service is that we give that reassurance out to you as our clients and our clients' family, that you do feel that that you do feel that not only with your carers but with the whole of the Good Care Group, that we are there supporting and we are picking up on things that we think need to be picking up. So we are now starting to think about winter planning, and because we have to think of all of where that will take us and the potentials of what will come out of not only winter but all of the other wonderful things that are going on at the moment. So I think that's when you are looking for care, that's one of the things you need to look at is the whole package, I suppose, really.
Jan, do you want to just if you flick to the very last slide, I think it's got my email address on, so just if anybody does have any other questions after this, or if we didn't quite answer your question, that's my email address and you can reach us on that number. So if anybody does think of anything after the fact, please let us know. And I'm sure I'm not speaking out of turn when I say that the client representatives that we have on the call would also be happy to talk to you.
Absolutely, yeah.
Thank you. Thank you all so much for coming.
Thank you
very much.
Thank you.
Thank you very much.
Thank you.
All right, bye-bye.
Bye.
Bye.
See you next week.